Good afternoon, everyone. So I'll be presenting a case for pedal access I did for CLI, no conflicts. So this is a 85-year-old male. He initially presented to my clinic with a right foot ulcer. His medical history was notable for kind of the usual cohort: hypertension, hyperlipidemia, CAD. He had a recent coronary cath and a stent placement about 4 months prior, as well as CHF with a decreased EF. He was on an aspirin, Plavix, and a statin, and he was a former smoker. On exam, he had a toe ulcer, which was non-healing. He'd had about for 5 to 6 months. He had no palpable pedal pulses, just signals, and he had palpable femoral pulses. His labs were unremarkable. So we did some office testing. We got ABIs, which showed they were decreased to 0.6 with blunted waveforms. And he also had a recent CAT scan about 2 months ago. So I'll show you some representative cuts here. So here you can see his aorta. He has a small aneurysm there. And then going down, you see both iliacs. And so the first thing to note is his iliac arteries are very tortuous, right? So trying to go up and over on this case would be very challenging. As you go down, you'll see that there's multiple bends, and especially in the setting of that small aneurysm there. And going further down, focusing on the right side here, you'll see that his femoral artery is also occluded just past the origin with just a profunda. And then farther down in the leg, it comes back above the knee. And he had I'll show you the angiogram, but he had a 2-vessel runoff, actually 3-vessel runoff. So just to summarize, it's an 85-year-old. He presents with a right foot ulcer with a SFA occlusion and tibial artery disease. So what are your options here? So as Dr. Lantis just mentioned, conservative management obviously isn't good to try to save his leg. Endovascular option is definitely a good option, but as we mentioned, there's some challenges with that, with the iliacs. So going up and over would be challenging, even to get a catheter, let alone a sheath. Even antegrade access would also be difficult because the femoral artery is occluded just past the origin. Thinking about the other options, so open surgery, he had recent stents and CHF, so he's not a great candidate. And he is ambulatory, so doing an amputation, especially for a toe ulcer, is not a good option. So we went for endovascular. And of course, this is a pedal artery access case, so that was our ultimate access route. But some other points to consider. So when I think about ways to access the vessel, so the typical kind of traditional one is contralateral, which we talked about. You could consider antegrade to avoid going through the iliacs, but you don't have any running room with this because the SFA is occluded right at the origin, so that's not a good option. Tibial access is a good option here because there's more than one vessel runoff and it's CLI. And it would be the most straightforward way to kind of potentially treat both lesions. So here's I did get access for a diagnostic portion from the other side just so I could do a complete angiogram since we didn't have any. And so here you can see how tortuous the iliacs are. So navigating that, even getting a glide catheter up and over was very challenging. Here's the common femoral, and you can see right at the origin, it completely occludes with a pretty robust profunda. Here we're looking right above the knee, which is where the femoral artery comes back. This is the popliteal artery that has a little bit of disease in there, but it's open. And then this is the runoff. So here you can see that there's 3-vessel runoff with a very diseased anterior tibial artery. The posterior tibial and perineal look pretty healthy up here, but if you go to the foot, and just talking about everything with angiosomes, he has a foot ulcer, and it's really the anterior tibial that's feeding most of that. The perineal and posterior tibial down here really just kind of taper off into nothing, so they aren't really good targets for healing a toe ulcer. So in terms of the technique, this was an anterior tibial artery access with ultrasound guidance. My typical cocktail for this is to give 200 mics of nitroglycerin, 2.5 of ramapil, and then 3,000 units of heparin. So once I get access, I inject all of that into the micropuncture sheath. And then I also give systemic heparinization. I think it's really important that you make sure your patient's well heparinized. So I check an ACT and make sure it's 250 to 300. And then similar to what we do for radial artery access, I put in a 5/6 slender sheath. So in this case, I put that into the anterior tibial artery. It was very thankfully, this case was pretty straightforward. I was able to cross it just with the V18 and an 018 quick cross catheter, and it kind of shot all the way up. And then we treated it with a DCB, a drug-coated balloon to the femoral artery, as well as a plain balloon, a nanocross balloon to the anterior tibial. Patient had a relatively kind of skinny ankle, so we were able to get a TR band on it for the closure.
Can I ask, Dr. Rao, while you're doing this, you showed that the dominant runoff to the foot is the AT, but you did see PT that came down to around the mid-ankle. Why not stick to PT rather than treat the access from the dominant vessel?
I think that's a good point. If you have that option and both are equal, then obviously treating the one that's not going to your wound or is kind of the more diseased one is the better option. But in this case, based on the angiosome and where the ulcer was, the AT was the better target to treat. The PT kind of tapered down to nothing, and there was really no pedal arch. So if I was trying to treat everything, the AT down, I think that was the better target because I could treat everything in one setting.
Just from an interventional perspective, when we're doing this, so what I want to know is which part of the artery we should access so that in case we fail, we at least leave a zone open for you guys to bypass.
Yeah, so I think that's a great point. So when considering pedal artery access, I try to go in a healthy segment. So number one, you don't want to stick the artery where it's calcified or diseased because you're going to have a higher likelihood of failure. I try to go higher up because I think it's easier to salvage if you stick around like above the ankle, because there you could potentially balloon and you could use a larger balloon. And generally the vessel is a little bit healthier there. I kind of shy away from sticking the dorsalis pedis or the PT in the foot unless I absolutely have to, because I think those are higher risk for failure. Also, I think it depends where your lesion is. So sometimes you need you need as much running room as you can. So if you have a very distal tibial artery stenosis or occlusion, then you're going to have to go lower down to get enough room to really cross it. And then the other things I consider are kind of what Dr. Hahn mentioned. So if there's more than one vessel runoff, I choose the one that, if we do have an access site issue, it's least likely to cause worsening ischemia, if I have that choice. So here's just some images for the completion. So pretty good result with this. And then you can also see the anterior tibial actually fills faster than the other vessels now. So this patient did pretty well. I maintained them on aspirin and Plavix. He was admitted just for observation and wound care, and he was discharged home. And his duplex at 1 month shows that both vessels are patent and the wound is well healing. All right, thank you.
Thank you, Dr. Rao.